Hello, everybody. We are here for another In the First. I'm Jim Weldon,
Rob Close.
Dr. Mary McCrossan?
and we're going to be talking about an issue that's popped up very timely because of some legislation that's coming up, and that has to deal with physician-assisted suicide. So, Mary,
Okay.
you are a physician.
Yes, yes, a medical doctor.
Yep.
To be
So,
a bit more specific. Yeah.
yep. Why don't you go ahead and explain what the issue is here?
Okay. So, and just one more line on my background. I'm a family physician, so I've taken care of patients at all different stages of life, and for the family part of that, I do take care of caregivers, other people impacted by the disease or the disability of people in the community. I'm going to talk about HB 140.
Mm-hmm.
And this is known as the End of Life Options Act. The supporters we'll clear up language right away here. Supporters like to describe it as medical aid in dying.
Right.
It's a little more accurate, I believe, to call it what you called it, Jim, which is physician-assisted suicide.
Correct.
Since suicide is self-killing, this is the terminology preferred by the American Medical Association, the largest doctors association in the country. And no, again, meaning no disrespect to anyone, I'm going to go for the most clear language that I can.
Sure.
Sometimes, too, people think medical aid in dying refers to other ways that we assist terminally ill patients, such
Right.
as hospice and palliative care. These things are not controversial. So I want to talk about why the supporters are interested in this bill. And they want to make sure we're providing great service and doing everything we can to alleviate suffering for terminal patients. And there's also a serious issue of autonomy, personal autonomy and freedom involved in this. So the way the bill would work is that a patient who has a 6-month prognosis determined by their attending physician or nurse practitioner should be told, is required to be told, that they have options. They can go to hospice, they can take aggressive treatment, they can take palliative care, or if this were to pass, they could request a prescription for drugs, which they could use at their discretion to end their life.
So the key component of that is that when they are told that they have essentially 6 months to live, and they are explained the different options, and most of us understand the value of hospice, they will be required to be told that they have an option of essentially ending their life.
As this bill is written.
Correct. I just want to make sure people understood that.
Right.
So if I'm terminally ill and my grandmother is, and I'm in the hospital, somebody's going to come in and explain to me, listen, you got 6 months to live. Here's what we're going to do to help make you comfortable and whatnot. And oh, by the way, if you don't want to go through this, we can end your life.
That would be the scenario. They would be required to tell you.
They have to tell you. Okay.
Right, your attending physician or attending nurse practitioner. And I'll talk some more about how that would all play out.
Yeah, and I'm sorry to interrupt on that.
No,
but
please. I want to be clear. I want people to understand.
I think the stunning, like if I just said, I don't know if I want to do this, is there any other option? Mm-hmm. And then they said, yes, there is this option. But no, I'm going to be told up front that this is an option. I just have a problem with that because it's planting an idea in somebody's head that they may not necessarily want to do. Do you understand where I'm going?
Exactly. And this has been a controversy and a problem for a lot of people, right? Because when you're the professional, years of training, licensed is there to take care of you, what we say matters. We do legitimize things for people.
Correct.
Right? And this is so controversial that, it's very difficult for a number that, not all, but for many of the doctors I talk to, they don't want to do this. And they don't even want to make this a legitimate or to appear to be suggesting this to someone. Okay. So it is problematic.
Yeah, that's the thing about suicide, too. Suicide is a very impulsive decision that people make. 9 times out of
Sometimes.
10, that's why there's hotlines. That's why there's, sometimes, sure. So if you're given news like, hey, you're going to have 6 months to live and, it's probably going to be painful. Oh, but if you don't want to do that, I can kill you.
And
or
again,
yeah.
it wouldn't be presented quite that way,
Sure,
but
sure.
that may be what some people hear.
Yeah.
And that's definitely a concern for someone who is vulnerable, right? Or just for someone
Yeah.
who's, I mean, for a lot of people, this is the worst thing they've ever heard.
It is.
And again, as a practicing physician, I don't know. I usually, and it's not, fortunately, I've not often had to give people that kind of bad news. But when I have, I usually have come at it as I'm able with as much hope as I can. We're going to
Okay.
check this out. I'm going to stick with you. We're going to get what specialty care we need that may be useful and that you might want to have.
So I wanted to talk about, and I'm sorry for interrupting
No,
you
I
before
want
we get into the
okay,
meat
yeah,
of this,
yeah.
but that is one of the things that I actually wanted to talk about is that you said we try to provide them with hope. There's things we can do.
Right.
The psychological impact and how people treat disease and how they react to it and their attitude on that. While the attitude may not necessarily prevent the final outcome, it can provide a very powerful aspect for them as they finish their life. And I think it can also potentially extend past that 6 months isn't necessarily 6 months.
Absolutely. Absolutely. Again, this is, I think, a big part of why there's reluctance as this is written to move forward. It's important to know our ability to make that 6-month prognosis, and this is held up in the literature again and again. It's not great, right?
My grandfather was given 6 months to live, and I think 15 years later he passed
Exactly.
away.
Exactly. And this is the legislature are going to have a lot of bills, a lot of serious bills, but this is the one that's life and death.
Right.
So we really need to get this right. And again, in your grandfather's case, yeah, I mean, happily, sometimes we're wrong like that, and that's great.
And he still had a great 15 years. It wasn't like he was suffering the whole time, and it
Right.
was regretful. But
Right. There are a number of problems with this. Let me just kind of walk through the safeguards.
Yeah. So, sorry to interrupt.
No,
but-
no, you're not interrupting. These are all important points that need to get made. But it's that the first pass, right? The first encounter is with the attending, who can say 6 months. You have these options, and only the patient can ask and say, yes, I'd like to know more about getting those drugs. No one can ask on their behalf, right? And they can come back in 2 weeks to get the prescription written if they've met 2 other requirements. So they need to sign a written form that outlines what they want and that they understand, and their signing must be witnessed by 2 people. Only one of these people can be a potential heir. There's no, and then only one, say, could be an employee of a facility where the patient resides. But it's otherwise not spelled out that there are other limitations. And again, one can be an heir, which is a little concerning.
It is.
It's not clear that these people need to know the patient. They are to attest that, as far as they can tell, this person is competent, is not being coerced. But I have a hard time telling that with a stranger. So it's not as safe as it sounds. I don't know that it will accomplish what is intended for everybody. This form has to be completed 48 hours, at least 48 hours before that second visit to the first physician or nurse practitioner. The other requirement is to see a consulting physician or nurse practitioner. This person doesn't have to be independent of the first one. And at one part of the bill, it says they will examine the patient and verify diagnosis, prognosis, lack of coercion, and decision-making capability. Later on in the bill, it says the patient needs to be evaluated in that second opinion, and those are different, right? Now that we have telehealth all over the place, I think I'm not sure, it probably goes with the higher standard, which would be to physically examine, but there is a little bit of confusion, at least the way I read this. So having gone through those 2 steps, so they've accomplished a 48-hour waiting period on the written form, which can be done within the 2 weeks. then the patient goes back to the first attending and again makes their request. And the attending, again, is to certify the patient understands what they're doing, they have decision-making ability, and they're not being coerced. If there's a doubt about decision-making by the first attending or the consulting, and I'm sorry if this is a little
No, no,
confusing.
no.
That's
Okay.
good.
If either of those professionals have a doubt, they are required to get a psychological evaluation and obtain a written record and put that into the patient's record. So if the patient has met these requirements at that second visit, 2 weeks later, the first attending can then send the medication, send the prescription into the pharmacy. Patient can pick it up and at a time and place of their choosing take the medicine or not take the medicine.
Okay.
So they're, again, these are all described as the safeguards. And of course, what are we trying to safeguard against? Why do we have safeguards?
Right.
And we've talked a little bit about the first one. We're trying to avoid misdiagnosis and giving this to someone who's not terminally ill. But with a 6-month prognosis, as we said, the data holds us up. The literature holds us up. We make mistakes all the time. The status of the attending is a little bit confusing. The attending is supposed to understand the patient's diagnosis based on training and experience, not board certification. They don't have to currently be active in that particular area of medicine. They do need to be licensed, state of Delaware. And that's why you don't need to be a physician to do this either, right? An advanced practice nurse who feels by training and experience qualified to make that prognosis can do that, can make that diagnosis. I think a lot of people are surprised that this is a little bit vague, right? It's not necessarily the cancer doctor who's saying, I know all the options, I'm up to date on everything
Right,
that can be
yeah.
done for your kind of cancer. It's someone by this vaguer standard. So again, another problem with the prognosis and even the diagnosis to some extent. There was a question when Swedish health authorities were looking at this model and considering it. They contacted the health authority in Oregon, which is the state in this country where this has been legal the longest. And they read the statute and reviewed it, and they wrote to the head of the health authority, and they said, well, we must be misreading because when we look at prognosis, there's no requirement that the patient be in active treatment. So they're saying, for instance, and that's, people are free to stop treatment, of course, but they're saying, for instance, if a person was stable on their treatment, but for some reason, whatever, depression or some other pressure decided to stop treatment, which might have allowed them to live for years, say dialysis, would they then qualify?
All right.
And they said, yes, that would qualify. Again, it's not what we
Can
expect.
can I just go just a higher? Let's go a 30,000-foot view.
Okay.
This would be a tough one because each individually here, because then I'll answer. Can you think of a scenario where you yourself would want this? Like, want the option to be able to end your pain and suffering through medical care?
So that's a great question, actually.
Yeah.
So I've talked to physicians with a lot more expertise in care of the actively dying, terminally ill.
Okay.
And my question to them, because this does come up a lot, is, tell me the scenario where you couldn't control the pain. Does that happen in 2025 when you have the right tools? And even a doctor that I respect a lot who disagrees with me on a number of moral and historical issues said, no, I can always stop physical pain. It's not easy and it might take me several steps, but if I have what I need to have, I can get that under control. They can manage the shortness of breath, they can manage the nausea.
Keeping the patient conscious, I'm guessing.
So,
Short of like putting him under and just.
yeah, he said once and at the most twice he's induced sedation, but it's extremely rare. But he said worst case scenario, he will do that. In general, they can manage. And the question, right, of awareness, because people don't want to just be unaware and on high dose opioids. That's and again, there's more data that shows as people adjust to the medication, they will be able to be alert and do what they want. As people are dying, at that stage, we're ill, and the sleepiness and slow responses, again, from the experts, have to do with the dying process, not the medications. And they feel confident they can adjust these well to give symptom management.
Yeah, my sister died of stage 4 breast cancer, and I was with her on that, the final hours when she died. So, and it was she was in hospice care in the home, but it was a challenging time. But the hospice nurse was very good, provided medication, but it was the dying phase of it where she became less lucid because of that process.
And less
So
attentive.
would that answer then be no?
No, and again, these are, so to some extent, these are personal moral decisions.
Yes.
Right, and I think we talked before about whether suicide is always impulsive. I think for people who are depressed and so forth, often, but not always, right? If you want to go back to ancient societies, right, people had a rational approach to suicide for a whole variety of reasons. There's this societies, right, where because of dishonor, one is expected to commit suicide.
Right.
We are in a different society.
So we can manage the pain, therefore there is no suffering, so therefore there's no reason. I can see people maybe, well, the cost of that, now I'm going to burn all my inheritance, and I don't agree that's like, I'm just trying to go through all the scenarios why people would make this choice. So if they're not in pain, then it would be something else, financial cost. Maybe they want to leave something behind for their kids, and so the medical industry doesn't suck up all the inheritance. Like that could be a reason why somebody might want to do this.
In Oregon, and we'll get to a chart that, when they ask, in the summary, why did people choose this? 8% are citing financial concerns.
Right.
And in the state of, and it's been increasing. Initially, it was 4%, and now it's up to 10%. It's 10% in Washington, 8% in Oregon. Both states that take pride in providing a lot of support. It's a form of coercion, right? It's why are you choosing this? Well, I kind of feel I need, or maybe I don't want to go bankrupt, or I'm not sure I can afford. And for people, and again, Jim, I'm sorry about your sister. I'm sorry about your loss. I'm glad you were able to go with her.
Sorry, I kind of glossed over that. Sorry.
No, but it's everyone who's been, with a dying relative. Very, very commonly, we know it's not easy to get the care that we would like to get, and Delaware does not have enough support, does not have enough palliative doctors. There's some procedures, again, we'll mention a website to check out, that people need to leave Delaware to get certain effective measures that alleviate pain. So that, that is where we need to focus, right? Because that is one of the goals. That's part of what's driving this movement to examine this potential option. But that's our goal. We have other ways we can do this. We have other ways we can help people. And we should. I think everyone agrees we absolutely should. It's not going to be easy, but we can do it, and it's worth doing. I did want to come back just to the issue of suffering and acknowledge, their suffering comes in many, many different forms. And I'm not sitting here saying I can answer the meaning of life for everybody. And
I was
make
hoping you had that answer, though.
well,
Why not? We've
Yes.
been searching.
keep searching, and
Keep
we can
searching.
certainly have.
Maybe
That's
that's the
another.
meaning,
That's
yeah.
another conversation. I'm here to talk about
honestly,
end of life
I think it
care.
ties into
Yeah.
this, though.
No, that is
I
well,
think
and depression, right? Psychiatrists I've talked to generally are really not happy about this. I mean, their profession is premised on the idea that they want to stop suicide and not participate, not support. They, this bill assumes that I can meet someone, see them 2 weeks later on based on those 2 visits, having told them they have a serious medical issue.
Right.
they're not depressed. And it also assumes that I may never see, of course, the way this is written, I may never see that person again. And yet they're good to go. They
I'm
won't be.
stunned by the vagueness of this. So I could go
Exactly.
to not to make certain fields of medicine not very important, but I can go to somebody who does plastic surgery. They are a physician.
Right. If
It
they're-
doesn't even require a physician.
you don't have to be a doctor. You don't have to see a doctor. The way this would be set up, right, it's by training and experience.
Yeah,
You'd have
but
to be able to defend that if you were ever called upon. But yeah, you don't, like I said, you don't.
Yeah. Okay.
And I don't mean to imply that supporters want this that way. You know, and I think, like you say, this is, people feeling a lot of compassion.
Right.
But again, the bill will be what it is. It will be how it is written, and
Right.
I that's why I think, certainly that's a big part of why I oppose it. It's why many people would oppose it, is because of these risks.
So going back, you said the psychiatrists don't favor this.
Many are very opposed to
Can
this.
you explain further why?
So it's risky, is right. Depression is difficult to diagnose. Depression is a common part of terminal illness, and the way we have this set up, it would be easy for such a person to sort of fall through these cracks, and for us to inadvertently be handing medicine and a medical endorsement to a depressed person and saying, it's fine to kill yourself. Here are the means. And what people need is support. They need treatment. They need encouragement. And that's just a much more humane way
Okay.
for us to function.
I'll just play devil's advocate for a minute
Please.
because I
Oh,
haven't
sure.
answered my view on this yet.
Okay? Yeah, it's a tough issue.
Think of pets. So recently, we had a cat that was end of life, and you take your pet to the vet because they're suffering. Well, okay, that's not even a good argument because the vet is always willing to try more medical things, but that's a financial decision. So I guess, yeah, I just talked myself out of it. Yeah.
Yeah.
Well, and
So
again, but some of the
Yep.
the autonomy concerns, we can't fix them all.
Yep.
Or I can't. I guess I can't say there's not an autonomy argument to be made. But I think it helps that people should understand, right? They can always refuse treatment. People can start treatment and discontinue it. If someone becomes unable to speak for themselves, but has a designated medical proxy, that person, after discussion with physicians, in certain circumstances, can discontinue the treatment, right? There's a lot of fear people have about being sort of trapped with a lot of medical interventions that they don't want, and that
Right.
will not where the benefit maybe of the treatment does not offset their fear of it or their discomfort, and sometimes the benefit is so negligible
Right.
that's an easy call. But people need to know legally, if you want off, you want to go home, you want to stop this, you want to try a chemotherapy, and then when it's too much, the side effects you feel are just not worth it, you can stop it. You have that autonomy now.
Right.
And not to be too brutal about it, some people I've talked to think that in the United States we have laws against suicide, and we do not.
I was going to ask you: is it illegal to commit suicide?
No. It is illegal to assist or
Correct.
encourage.
Correct.
I would say that's where my position is on this. So we approach very dangerous ground by allowing our medical community to do this. If a person is terminally ill, if they are, still capable to go to doctor's appointments, 2 weeks apart and go through this whole process, and they still choose suicide at that point, there's no need to get the medical community involved. Like, they could just do this on their own.
I would, of course, always encourage them not to.
Yeah,
and
of course,
especially
of
to
course.
think about the survivors. But as the laws are now, you don't need someone with a medical license. The big difference is that your insurance policy, your life insurance policy, could deny you benefits.
Right.
If this were to become law, they can't.
They could deny you benefits if you tried it and failed and needed medical treatment.
No,
or,
if-
or
No.
If you bought a life insurance
Depending on your
policy,
policy.
oh,
If
the
you commit
benefit-
suicide, you
I
may.
thought most of them though, like 2 year
depends on the
rider.
policy.
Like you've got 2 years, you can't commit suicide within 2 years, and then after that you're covered. But
we'd have to, I know, in the bill
Sure,
it specifically says if you took the steps in this bill, then,
So-
but that's a difference in how the law would
Understood.
impact. That's what the difference would be.
boy, it's a tough one because you
is.
go through scenarios, right? You don't want to.
Well, and that's the problem, right? This is a law for everybody.
All right.
And I don't have a problem saying, I understand why some people, free will, but the problem is you've passed this, and I'd like to get into this a little bit more.
Yeah.
There's a cost, right? There's a cost for the person who is misdiagnosed. There's, again, the risk for the person who was depressed more than we knew, who really wasn't fairly treated and recognized because this is too difficult to do that. And coercion is a really important factor here. Interestingly, the disabled communities generally come out and oppose this. I mean,
Sure.
there are disabled individuals who say they want it, but if you look at it and listen to their stories, right? If you have a visible disability and you present to a medical facility, and heaven bless all those young, healthy doctors and nurses, they, and a common bias is to look at this person and say, I wouldn't want to live like that. I don't know why they want to live like that. And there's a real, it's more difficult to get aggressive treatment. It's more difficult to get the right kind of workup. And it is that bias that makes this very frightening for those groups.
Right.
Subtle coercion, right? Inheritance is real, but also just the day-to-day burden of caring for someone with disability. Again, in Oregon, when they asked why, the fear of being a burden comes up more often than the fear of pain.
Yeah. Is it time to bring up the Oregon website? Oh.
Let's do that. Nope, that's an even scarier part of this, if that's
Yeah.
okay. But I do encourage, anybody can go on to the Oregon Health Authority Death with Dignity annual reports, and they do probably keep the best records in the country, but we're going to show you why those aren't very good records, actually, when we get to this next page. But I do want to talk about the why and the factor of coercion. And it's a subtle coercion, right?
I would be more worried about the health insurance companies with coercion, because you got your actuaries sitting around. Oh, if we deny treatment for these 4 things, then people are, we can see in the data that they're just going to choose this final option, and we can save $50,000 per patient that gets this disease through self-assisted suicide.
In Oregon, that's been documented. People with malignancy, where the odds of success of treatment were judged by the actuaries to be too low to be worthwhile. And so they weren't very sophisticated about this. They sent people letters saying we are going to, and there's a lady, an advocate who will be visiting Delaware, who's in this situation where she has the letter, and they said, we're not going to treat you, but you need to be aware of your right as an Oregon citizen to have medical aid in dying, and your
Wow.
copay is $1.40.
Wow.
So it's
man.
not theoretical. There's a reality to it. I think, again, everybody knows how difficult the medical system can be, right? The denials for medical equipment like wheelchairs. And sometimes I've had patients whose wheelchairs needed repair. And again, we have to go. And people listening may well be familiar with this phenomenon where, you have to get the authorized person to repair your wheelchair.
Right.
And they may or may not come this week or next week. And it's very discouraging. And again, it's, in a sense, kind of a coercion, right? What's the way out of this situation where we're not giving people support that we could provide, but we have this other option? We need to clean up these other things. But it's, especially as everybody, when we get a serious disease, in a sense, we are disabled at that point, right? And it's tough, and especially if you don't have support. We talked about just day-to-day getting home care, burning out caregivers. and how people fear that being that kind of a burden. Some people aren't blessed. There are a lot of fantastic family members and caregivers in the world. I mean, they are my heroes. Some people don't have that, and they're really struggling to get just day-to-day things done. Again, this has been part of practice, right? Is calling this agency and that agency and trying to get this kind of dressing, and then finding out the medicine I'd recommended didn't get filled because this person's insurance changed and it's not on the list, but nobody knew, but we don't know what med is on the list. I mean, everybody who's had any serious illness knows this.
Right.
And again, I wanted to make the point, a couple more points about terminal illness, and then, we will address the question of the track record in other states. In the bill, it specifically says an illness where someone says there's 6-month prognosis is terminal if it's irreversible and incurable. That's not the same as untreatable.
Or
Right.
it leads to death.
If you stop treatment, I mean, and again, I don't mean to say this is what people intend, but that's what the bill says, and that's why it can be interpreted, right? All the chronic diseases, diabetes and elevated cholesterol, and
Life is a terminal illness.
there you go. There you go. So it's not,
wow.
it's
Thanks,
not,
Rob.
yeah.
Hey, I'm right there with you. I'm
Yeah.
just,
But I think you're right.
just a couple laps behind.
When people
Yeah.
picture the scenario, they're thinking of a much more clear, definite diagnosis, not these vague things, right? And to give one of the ultimate examples, and this was published in a medical paper, medical aid in dying or assisted suicide is legal in Colorado. There is a doctor there in internal medicine who was called in or came to be dealing with 3 women with anorexia nervosa. And these are not old women. These anorexia patients tend to be younger. And for all 3, she determined they met all the criteria for terminal diagnosis.
Wow.
And it's clearly a mental illness, it sounds like.
Right, with significant physical consequences.
Sure.
So these 3 women were all provided by their physician drugs with which to end their lives, and they did. And she published a paper to brag about this. Brag isn't maybe the right word, but to say how, great example of a way you can use this. She was not sanctioned. She has her license. She's free to go on. Some people said, well, we don't think this is really the spirit of the law, but there's no consequence.
Right.
So again, just like you're saying, everything is vague, it's kind of watery, and we can have some really unintended consequences. And I think disabled people are entirely right to ask that this not become law.
Oh, yeah.
Because
sure.
the safeguards don't work. I mean, the safeguards, we just walked through how all these safeguards fail every step of the way. So if we want, we can, we're often told that, the track record in other states is really good because this has been around so long and there aren't a lot of complaints, but this would be a good place to put up the chart. This is from the Oregon Health Authority, their most recent summary, and I'm going to look at it from this way. Okay.
Yep.
So in Oregon in 2023, let's see, is that up? We'll make it bigger so everyone can see it.
I hit the wrong button. It happens.
There we go.
So they can see it on the screen.
Yeah. So do you think that's big enough? Everybody can see it at this point?
How do I do full screen here? Sorry.
Oh, okay.
Oh, you can keep talking though.
Okay.
I'll figure it
Yeah.
out.
So I'll start at the top. So in Oregon, their process, is very similar to the one in our bill. And they will, when the attending physician initially starts this process and writes a prescription, they submit a form. They're expected to submit a form to the health authority. And as death certificates roll in, the health authority will match up the patients. So based on the assumption that all the doctors completed the form and self-reported that they'd completed the form, if that's accurate, 460 people got these prescriptions in 2023.
Okay.
And if you go, down
560? Says-
560.
Yep.
Okay. So 82 did not take the medication but died naturally. And then going to the left, 337 took the medication. They always have people from the year before who got their prescription, say, December of 22, and then died in 23. But if you go to the right, that's where it kind of gets interesting. If you go to the right side, that leaves us 141 people who may or may not have taken the medicine.
Okay.
And if you go down, 41 of them are dead. We know that. They are deceased, unknown ingestion. But what's really concerning, if you're relying on this data, to assure yourself that this is a safe, tight process. Bottom right, we have 100 people who may or may not be deceased. So how
did they die?
Right. And again, if when we think about the death penalty, I think we are appropriately very, very careful and cautious in saying we don't want one death that should not have been.
Right.
And if we look at this data, we go, oh my gosh,
That's a lot.
what are the odds that amongst those 100 there were deaths that should not have been?
Correct.
And furthermore, if we go even back to the left of the chart, since there is no required medical supervision at the time of ingestion, what are the odds that of that 300 some people, they were no longer capable of making that decision on the day of their death,
Right.
or they had become depressed, or they had become less than lucid, or someone else wanted to accelerate. Again, I can give an example or two. There is information out there, but in Oregon, of note with our bill, HB 140, there is no fiscal note, which means there is no funding
Right.
to investigate concerns or complaints, right?
All right.
Oregon is the same. And they, when complaints have come up, they can send a note to the medical society or the medical, licensing authority. But they've said their job as health authority, which would be the same with our health department here, is to collect data. They're not investigators. They're not equipped. So all, I know these are just numbers on a slide, but these are also all individuals, and we don't know. We really should not be comforted or assured that there are no problems.
Yeah. So you mentioned the website, stop140.com.
Stop HB140.
Stop HB140.
.com. And I think, do we have a slide we can show? That's an excellent source.
Yes. So
Of
if people had
information.
questions, that's a great source to go to see if they can get some of those questions answered, right?
Absolutely. And it includes the references. So you can, back
There it is.
check. Yes. At the bottom of that site, for people who want to share this information with legislators, and I think a lot of the legislators have not heard this, I think it would be a wonderful chance to find out who your legislator is and to send them a respectful note or meet with them in person and share the information. Because I think most of them don't want this. When this bill was going through a year ago, it was not a slam dunk, right?
Right.
It was very, very tight and very, very close. This is not something that there's a lot of enthusiasm for. So, and hopefully, my hope is that as people get more information, they'll see the flaws and will step back,
Now,
do better.
it was going to come up this week in the House, but it's been delayed, correct? So, I mean, if people have questions, they should actually start to do something because there's not a lot of time period.
And we don't know, right? It
Right.
came out of committee. It's on the ready list. We've been assured by the leadership in the House it will not be heard this week.
Right.
And it may never be heard.
Right.
They may decide. this
Or they
is
could just
something
say, oh, you know what, we are going to do it.
It's up to them.
It's up to them.
But I think to your point, don't wait until June. Please
correct.
touch base with people now.
Yes.
Okay.
All right.
That was, just sitting here and talking through this. It's not really something I've ever really spent a lot of time thinking about or in
Right.
detail, any level of detail. And there was definitely just a flood through my own consciousness about thinking through this whole issue. And at first, at the surface, you're like, well, sure, if you're in pain, somebody should, end the pain. We want to stop the suffering.
But
Then
how
when you
can-
really think about it, well, no, we can manage the pain. That's fine. But allowing our medical profession to do this opens up such a huge can of worms.
It does.
Not even thinking about the moral implications.
Right.
Just the toll that it's going to play on doctors and healthcare workers. Do no harm. Well,
Right.
So-
And I don't want to keep you gentlemen here
oh no,
all
no,
night,
we got
but,
lots of time to.
one of my psychiatrist friends has looked into this and said, again, in Oregon, where the data is the best, there are a number of physicians who did this once or twice and never again.
All right.
And he
It-
has looked
it's
into it, and he said
permanent.
they are traumatized
Right. Sure.
and they regret it. Another huge factor is there's looking at the states again where this has been enacted, right? They start out very similar to what we have here, a 2-week safeguard waiting. And what happens often is today's safeguards become tomorrow's barriers. So what they found in some states is a number of people will die naturally before that 2 weeks is up. So they shorten the waiting period to 48. I know, it's ironic. They go to 48 hours.
Yeah, so once you open the door, basically.
Right.
Now,
Right. Once you cross that line and say the medical profession, the nursing profession, it's okay for them to hasten death deliberately on request.
Right.
I think a number of listeners are familiar with how this progressed in Canada. It went really fast, where a patient with chronic illness went to the courts and said, this is a bill to relieve suffering. Well, I'm suffering, I just don't happen to be dying. And the court said, well, based on precedent, we have no argument against this.
Wow.
And so it is, again, Canada's, if you really want a fearful set of outcomes, just start reading about how this is managed in Canada.
Okay.
It's terrifying.
yeah, I
Right.
think my set position is the healthcare industry should not be any part of that. Like, that should not be on the table for them because it could snowball into something totally unintended. And, we've talked many times about unintended consequences
Exactly.
of various bills and policies that our government has and the outcomes of that, which we can see every day, looking at the news, the outcomes of best intentions. What is that saying? The road to hell is paved with best intentions.
Yep.
I mean, we get it. I get the compassion side of it.
Exactly.
Your loved one is suffering, physically, even mentally, but we can manage that if you get to the right healthcare point. And now, if the argument is, well, healthcare is too expensive, I mean, that's a completely different argument. That's not the solution to that. Is not to, well, let's just kill people when they're suffering.
Right, that is part of the coercion fear,
Right.
right?
Yes.
It could be
Yes.
rather subtle, but it's real. It's like it's 8% in Oregon, of all places, a rather socialist-leaning state.
Yeah,
8%.
sure.
That was part of what was pressuring them
And
to end their lives.
we talked at the beginning about the meaning of life, a little
Oh.
bit, and maybe that all life has purpose. I believe that. No religious undertone to that whatsoever. Like, it's just, I think we're here for a reason, and I think part of that reason could be in your end of life experience to be an example of why healthcare needs to get fixed. It could be that if it's so expensive that you're burning your entire life savings and your inheritance, for the last 6 months of your life just so you don't have to suffer. Well, we need to look at that. We need to fix that, and maybe that's part of your mission here. Whatever you believe, if that's your purpose. So that's
point.
Yep.
can
that
go
is
there.
a thought process I've never gone through.
Yeah.
But as I age, I'm getting
There you go.
getting up there.
Uh-huh.
not so
All
much,
right.
but-
Thank you. Yeah.
Well,
Okay.
thank you so much for
No,
your
you're
time,
welcome.
and thanks very much to listen.
Yeah. So this is a very interesting topic, and
I'm not going to sleep good tonight after this. I want you to know. Like,
watch this, share it, have discussions about this. If you're compelled to feel that this is not an action you're comfortable with, then you should be contacting your members of the General Assembly who are going to be voting on this, and express your concerns. If you like what you've seen here, please make sure you hit like. We are on YouTube. Share it and subscribe, because we're got a lot of interesting topics and very, very powerful issues. So, Mary, thank you very much. We appreciate you coming in. So
yes, thank you.
this is end of first, talking about physician-assisted suicide is what I'm going to call it.
That is the proper term.
Yes.
Okay, the leading medical authorities describe it as such.
All right. Thank you. Thank you very much, everybody.
Bye, everybody.